Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, the executive editor of MedEvidence. And I have a really special guest today who is part of our Master Series, where we take the best and the brightest, and we have those people break down their area of medical expertise and share that with our listeners and viewers and break it down from the standpoint of a patient's journey. And today I'm delighted to introduce Sue Jane Grosso-Rivas, who is an expert on breast imaging. And her current position is breast imaging director for Summit Health, but also lots of other wonderful things on your resume in terms of advising the FDA on accrediting breast imaging organizations. And I think, if I remember correctly, you also have a role as an expert with the American College of Radiology. So you can break that all down for us, Sue Jane, but welcome to MedEvidence. Thank you so much for being part of this podcast.
Thanks, Mike. Very happy to be here and happy to share whatever information I can to enlighten everyone about breast imaging. Absolutely. Thank you.
So Sue Jane and I had a really interesting interaction actually at our reunion from Harvard Medical School. And I won't say what number reunion it is because I want to protect the innocent from identity theft and age discrimination.
Very glad to hear that. Most people don't know my age, Mike.
Well, I wouldn't have known your age except for the fact that we went to medical school together.
That's right. I started very early.
There we go. That's a good thing to tell people. I love that. But anyhow, so you shared a super interesting story about how you built the confidence to actually go into medicine and ultimately apply to Harvard. And it was interesting to me because we both have the commonality of having grown up in New York City and having experiences there. And so I'll let you get to that in a second, but it was a fascinating journey and it was part of the reunion, which is my favorite part of the reunion, where all of our classmates just kind of shared their stories. And one of the wonderful things about getting older is that you get very comfortable with yourself. You use the term, you feel good in your own skin, and you're less worried about what people think and more worried about sharing your experiences and maybe helping other people by virtue of the sharing of those experiences. So,
absolutely.
So tell us a little bit about how you grew up and sort of repeat the story that you shared with our classmates.
Mm-hmm. Well, Mike, when I wrote my report for the reunion, I decided that I wanted to share my story and tell what I considered the truth of who I was. I feel that a lot of times people, don't, just by looking at me, you can't tell, right? You can't judge the book by its cover. You have no idea where they've been, basically. And I thought that it would be a story that maybe would motivate others or inspire others. And so I did want to tell the story. And I titled my story, if you remember, it was called East Side Story.
Mm-hmm. Yeah,
and
I love that.
The reason it was because my favorite musical was West Side Story. And it was because I felt that it kind of told my story because my mother was from Puerto Rico. She came to the United States at about the age of 18. And my father was a first generation Italian American. My grandfather came from Italy and settled in the South Bronx. So my mother, being the Puerto Rican from, let's say, West Side Story, and my father, who was Italian, not Polish, as Tony was in West Side Story, but the fact that their union was not a common one back in the 1950s, and in fact, it was a beautiful love story, certainly, but my mother was not accepted by his side of the family, and so unfortunately, it led to them breaking up. They were separated. And, I ended up raised by my mother alone. So it was a single parent household, which then changed a lot of things for me. And it was, living in a lower income neighborhood, basically. And I was going to a school in East New York. And it was at a time when they started to bus students. It was part of the desegregating program. I don't know if you remember from that time. They were trying to create equality in education by taking students from one from a lower income neighborhood and bringing them into another neighborhood. So I was bused from the east side of Brooklyn to the west side of Brooklyn, and that was Bensonhurst. So I ended up in Bensonhurst, where there was a better educational opportunity for me. I ended up in it was elementary school. I started at fifth grade, but I remained there, even though I moved. In Brooklyn, my family moved to several different parts. I continued to travel to Bensonhurst, and I ended up at a high school, New Utrecht High School, that was a great public high school. They had honor classes. So there were other students that were interested in learning like I was, which is very important to be surrounded by people that are similar in as far as their goals. But as you remember, the story was that what really changed things for me was when I went to my high school counselor, Sylvia June Goldberg, and I'll never forget her. I went there and, as many counselors sometimes do, right? Not all of them are great, but this particular counselor asked me what I wanted to be. And I said, a secretary. And she looked at me and she said, a secretary? And I said, yeah, a really good secretary. I'm going to be a bilingual secretary. I'm going to be an executive secretary. I'm going to be the best secretary there is. And by the way, I did take typing, and I was very good at typing and very fast. And that's one of the best classes I've ever taken. So anyway, but she looked at me and she gave me the lecture that would change everything. She started out telling me that I could be anything I wanted to be. And she described that there was a ladder that would reach to the sky, and I should climb this ladder to the top. And if for some reason I couldn't get to the top, it was okay to come down one rung, right? She said, I could be anything. I could be a doctor. I could be a lawyer. And it just opened up my eyes to something I never really thought about. I was very good in science. I was very smart. There was no doubt about that. I was excellent in the sciences, excellent in math. And so I thought, okay, so I guess I could be a doctor. And then I said, well, what about a nurse? I could be a nurse too. And she looked at me and said, well, let me ask you this question. Do you want to tell people what to do, or do you want them to tell you what to do? And I thought, oh, I want to tell people what to do. And to think that at that age, I don't know, maybe I was 13, 14 years old, 15, I don't remember, but it was so clear to me. And I went home that day to my mother, who was in the kitchen cooking some fabulous Puerto Rican meal. And I looked at her and I said, Mommy, I'm going to be a doctor. And she looked at me and she goes, okay, but never expected that I would reach those heights. But it was all because of Sylvia June Goldberg. She really started me on that path.
Well, that's fabulous. And we take our hat off to her. Is she still with us? Is she still alive?
No, unfortunately, She is not. I have looked her up, and I feel badly that I didn't get to speak to her to thank her. And I even looked her up to see if maybe she had children or there was someone that I could connect with, but I have not been able to find that. I don't think she had children. I didn't find that information. So it's unfortunate. I did try reaching other teachers that I did.
I'm glad that you're able to give her a tribute. That's fabulous.
Yes.
I will say that clearly she was an inspiration to you, and I'm sure to many other students. But she may not have understood medicine exactly, because in my experience, the nurses tell the doctors what to do.
Quite right. I mean, look, nurses, extremely important. Love all of my nurses, for sure. But ultimately, as a physician, you do have to end up making a lot of the decisions. So, people, sure, even with what I do today, as they say, the buck stops with me. It's like they expect me to make the decision for anything that's going on with a particular patient.
Yeah, absolutely. Of course. So tell us a little about your journey from graduating medical school to your training. How'd you end up getting involved in breast imaging? Where were the inspirations there, and how you eventually got to where you are now, which is leading a big group at Summit Health. And along the way, you can mention that we have a number of commonalities. You probably don't know this, but I was actually born in the Bronx. I was born at Bronx Lebanon Hospital, and I grew up on Staten Island, where I know that you spent some time. So maybe share with us and the audience exactly how your path played itself out.
Well, as you remember, Mike, when we were at Harvard Medical School, when you are in medical school, you get to do many different rotations as you're trying to figure out what kind of a doctor you will be. When we were at Harvard, if you remember, they really pushed primary care. Do you remember that? Primary care was something that was valued very much. And I thought I would be a primary care physician, a family physician. I knew that I loved taking care of people. I knew that. I knew that I wanted to, probably be a primary care doctor. However, as I went through my rotations, one of the rotations that I went into, and I'll tell you, I really enjoyed all of my rotations, every single specialty that I went through. I would go, I don't know if that happened to you, but I'd go to psychiatry, something in psychiatry and think, oh my God, this is great. I could be a psychiatrist. Or I, do OB, and next thing you know, I want to deliver babies. So everything excited me, including surgery. When I did it at Mass General, I thought, oh my God, I have to be a surgeon. But when I did radiology at Mass General Hospital, I don't know where you did your rotation, but it was Dr. Noveline who was in charge of the program.
Yeah, I did it there as well. Yeah, I did.
You do that one?
I did radiology and surgery at Mass General. Yeah.
Okay, I did both also at Mass General, but it was so well organized. And I don't know if you remember when they put us into a room to sit down and look at cases, right? So there were these folders. They were called the American College of Radiology folders of images. And I know this may sound corny, and it doesn't even sound like it's possible. However, I reached into a folder, I pulled out an image, and I put it up onto the view box, which is what radiology does. And I tell you that it clicked for me. I looked at that image and I felt like it was comfortable. It felt like this is something I wanted to do. Then looking back, I realized, well, when I was in high school, I did take a course in photography. I was very interested in art. I loved anatomy. And I think that looking at an image, right, it was black and white. So that was photography. And then you had to go through a differential. And you had to kind of figure out what was going on based on that image. So for me, I found that very exciting. I thought and not only that, with radiology, it involved all specialties, right? So it involved orthopedics, gynecology, oncology. It was all there for you in radiology. However, I will say that once I started my radiology residency, which was at New York University, I didn't realize that radiologists, some of them do not have much of an interaction with patients. If you've heard, radiologists are people that, those are doctors that don't want to see patients. They don't want to interact with patients. And that was not me at all. So when I was doing my radiology rotation at NYU is when mammography was just starting to get to be popular. There was no fellowship in mammography at that time. And I met a professor that was brought in to NYU to head up the breast imaging department. And that was where I found my patient connection again. Because in breast imaging, we talk to the patients. When they come back with something abnormal on the mammogram, we see the patients, we interact with the patients, and I also do biopsies. So it sort of gave me the opportunity, how I wanted to do procedures when I saw surgery. So it gave me a little bit of everything. And not only that, with breast imaging, I was also able to do some work in the community. So a lot of public speaking. And I wanted to help women. I became clear I wanted to help women. And so I wanted to go into breast imaging. And I knew that I could help them not just individually, but being a radiologist with a specialty in breast imaging meant that I could get on that bandwagon where everyone was talking about screening mammography and how it was so important. How do you get that message out to people? So I did a lot of work out in the community, whether it was radio, TV, public speaking, just trying to bring the word out to everyone about screening mammography. Until this day, I still do that, which is, describing the latest technology, whatever it is, to go out and educate the people. So for me, it was a perfect fit. I felt like I had found exactly what maybe I was meant to do.
Beautiful. I love that. I love that.
It was for me.
Yes, you just triggered our memory. I remember during our Mass General Radiology clerkship, Lucy Squire was the leader, who was a female. During a time period, there were a few physician leaders who were female who basically had set up the entire course and the training at one point. I don't know if that was an inspiration at all, but it was something I remember, and to me was kind of neat to see that.
Yeah, no, it's true. Actually, when I went to NYU, they would only allow maybe one woman per year. Actually, if there were 8 residents, there was one woman. My particular year, they did take 2 women. But even back then, I mean, in radiology and even the practice that I joined eventually, I mean, I did go to Staten Island, and I guess I should go back to how I ended up at Staten Island. But when I eventually ended up in New Jersey, I was part of a group, a private practice group, and they were predominantly all men. I was the second woman to join in 2001. So nowadays, there are a lot more women in radiology. But Staten Island, how did I end up in Staten Island? Well, when I graduated NYU, I actually went to California for a little while. I was there for about a year and a half. I joined a group that had connections with University of UCSF and also Stanford. So a lot of the radiologists came from those groups. And I was there and I wanted to do breast imaging as a specialty and also nuclear medicine because I did both of those. But they weren't ready for what I wanted to do. And in Staten Island University Hospital, the person that was in charge of the radiology program was a woman, and she was at the cutting edge of where breast imaging was at that time. And she created a little women's imaging center with all new mammography machines. And at that time, nobody was doing breast biopsies on Staten Island. I'm talking about not the breast biopsies in the operating room, but the minimally invasive breast biopsies that are image guided. So she brought me in to create that program, which meant that I had to go up against surgeons, right? Because surgeons were used to taking patients to the operating room for any, biopsy, many of them which were benign. So I had to start up that program, start up a screening program. And so that was very exciting. That's how I ended up at Staten Island University Hospital. I was there for about 8 years until I had an opportunity, to come and join a private practice. Again, joined the private practice only because it was an opportunity to start a program that they didn't have before. So I was always looking for leadership positions, something where I could make a difference and create a change that was ultimately helping the individual woman, but also helping the entire community.
Yeah, absolutely. So we definitely both share the Staten Island parts of our story and the desire to make a difference. I think it's a characteristic that some people in medicine have and others don't, and clearly you have that. So one of the reasons I was so impressed by your little speech at the time of our reunion. But let's transition from here and talk a little bit about the patient journey. Obviously, when you talk about breast imaging, you talk about lots of people. Obviously, over half of the American population, and maybe even some men you can throw into that mix as well. I'm sure we'll get to that. But you talk about something that creates a lot of concern, anxiety, and ultimately something that is incredibly important in terms of the early diagnosis of breast cancer and hoping to minimize the impact of that disease. So kind of walk us through a little bit about general recommendations for women, and then we can talk a little bit more about people who are at higher risk and how you might tailor the strategies for those folks.
Well, I think let's start at the beginning as far as breast health, right? How do we maintain breast health? And at one time, and you may remember this, the American Cancer Society, right, which is one of those societies that we look to help us figure out when to get your mammogram, screening. And do you remember when they would talk about breast examination, self-examination?
Self-exams, yeah. There was
they used to say, make sure that and there was a big, push for this is how you do a self-examination and so forth. So when they were talking about how to find breast cancer, they would say, get your mammogram. And they would say, examine your breasts, right? This is the way you do it. Go into the shower, so on and so forth. I don't know if you know this, but they no longer recommend that you do breast self-examination.
Interesting. Yeah, I haven't
which
heard.
is very,
Now you
yeah,
bring
you
it
didn't
up.
know
I
that.
haven't heard that lately, and that
Yeah,
makes complete sense.
yeah,
But you're
but
absolutely
they,
right. It was a huge point of emphasis about how to do self exams and what time of your menstrual cycle you do it and all that sort of thing.
right,
So yeah,
exactly, but they don't recommend it anymore. But
interesting.
I'm going to tell you that as a person in this specialty, I still think women should do breast self examinations. Um, the reason they stopped recommending it is because when they looked at the studies didn't show that it made a difference, right? But I can tell you story after story of the woman that has come to me and has found her own breast cancer. Okay. So, yes, we're going to talk about how you should get your mammogram, right? But I really want to emphasize how women have been their own advocate and they have saved their own lives by finding their cancer because they felt something and they came in to see the doctor.
So interesting.
Okay. Yeah.
So your recommendations: once a month, twice a month.
You
How
know,
do you?
I would say it. I don't think you have to. I don't want to put that pressure on women, and I think that's one of the reasons why they. If a woman doesn't want to examine her breasts, I'm not going to push her and tell her that she has to. I think it's just becoming familiar, and I would say every so often. Maybe that would be every 2 or 3 months. It's just, let's put it this way: if you're in the shower, pay attention, see what your breasts feel like. Now, so of course, some women will say, oh, but they feel lumpy. I always feel something. I can't tell. And I try to tell them, believe me, when there's a cancer, it's going to feel different from anything else that you've ever felt in your breast, right? So while I don't want to say that they have to examine their breasts every single month, that's not what I'm trying to say. What I'm saying is, I think being familiar with your breasts, how
Got
they
it.
look when you look in the mirror, right?
Makes
Looking
sense.
in the mirror, is there a change with the way that your nipple looks? Is there a change with any of the color of at all of your breast? You see a dimpling. Does one breast look different from the other size wise? I think it's important to know what your breasts look like. Believe it or not, sometimes women have come in and I ask them, I say, well, how did you find this? And they'll say, well, my husband found it. I've heard that. I've heard where my dog kept going to this one part of my breast, and it may be because maybe the cancer was very warm, right? Because of the extra blood flow or something. I've heard that story too. But, women should get their mammogram. I mean, let's start with
And
that.
just before we get off the breast exam,
Yeah.
any advice vis-a-vis time of the month for women to examine their breasts, or doesn't
I
matter
think
that much?
that's a very good question. And I think let's bring up the question about breast pain, right? Because when you talk about time of the month, it's a woman who is menstruating, okay, can sometimes have tenderness of her breasts. Now, most pain is not associated with breast cancer. Pain that is cyclical, meaning you can feel it before your period and then it goes away, comes and it goes. That's not the kind of pain that is associated with breast cancer. And you're right, as far as the best time to examine yourself will be, after you had your period. So let's say at that 5 or 7 days, it's when your breasts become most quiet, as opposed to the middle or right before your period is when women, are a little bit more tender, tend to be a little more full. So, and in fact, we don't do this so much anymore, but when we do breast MRI, and we'll talk about that at some other point, we would try to schedule it at a certain point of their menstrual cycle because the breasts are not as active. The breasts are very active, like right before your period. I think most women could probably would agree that that's when they feel it. So, yeah, I mean, to have to remember when to do it, better to just feel comfortable to do it
Gotcha.
whenever you feel you want to. Yes.
So moving on to mammography, I know you wanted to give some people some recommendations with regard to when that should be done and how frequently.
Well, I think it's an important topic about when to start screening mammography. And the reason why is because there has been a lot of controversy and there have been some differences among different organizations. And the differences tend to be the age group between 40 and 50, right? Between 40 and 50, it was not so long ago, the United States Preventive Services Task Force, they had said that women between the ages of 40 and 50 did not require a mammogram. And that is not what the American Cancer Society said and not what the American College of Radiology said. But recently, they changed their minds. And they have said that women from the ages 40 to 50 should get their mammogram. So if there's any woman out there listening, anyone listening that's been a little bit confused with everything that has been said, the bottom line is you start at 40. That is the age that you start. Now, that's for women with an average risk. They don't have an increased risk. They are just average risk. Now, some organizations, the same one I just mentioned, says that you should get a mammogram every 2 years, biennial, between the ages of 40 and 50. Actually, they may actually say biennial from 40 all the way to 74. I have to check my records on that. But the American College of Radiology recommends that you do it every single year. So that is my recommendation. So does also the American College of Breast Surgeons say from 40 every single year. The American College of Obstetricians and Gynecologists also says the same. So age 40 every single year. Now,
any concerns about the radiation risk? I know that's been thrown out there as a trade-off.
Right. Well, look, with anything in medicine, it's always about benefit and risk, right? You have to sort of look at what is the benefit, what is the risk. And with all of these guidelines, everything that we're talking about today, you should always talk to your physician because your physician should be able to guide you. Oh, sorry, there's a bug. The physician should be able to guide you. They should know the information. If they don't know the information, they should call their radiologist. And I do get a lot of calls from my primary care, colleagues or gynecology colleagues that will call me to ask me, what should I do? And that's what a patient should do, is they should speak to their doctor. Radiation, yes, there is radiation, but it's a low dose of radiation. And you can see, statistics out there that will tell you, one mammogram is about 26 days of background radiation. And, we're not talking about other parts of radiology, but CT scans of the abdomen and pelvis, for example, a lot more radiation than a mammogram. Chest x-ray is a little bit lower. So you have to sort of think about the benefit versus the harm. The radiation is very low. And especially nowadays, we have digital mammography, and digital mammography is lower than film screen mammography, which is where we had started. So I could understand being concerned about radiation. I get it. But the benefit far outweighs any risk with radiation.
And that's helpful. So how about this concept of having the study done in the same place each year so it's easier to compare?
Yeah.
I'd love to hear your comments about that.
Yeah, that's a very good point. I'm glad you brought that up. It's very important for women to realize and know that we need to compare to priors, because sometimes the only way you can detect breast cancer is when there's a change in the appearance of the breast compared to before. So while I would tell you it is better to stay at the same facility so that they have the same, all of your images from the past, I don't want to say that you have to stay there, because what if you find another place that you prefer? What's most important is to get your prior mammograms and bring them with you to whatever facility, if you choose a new facility, right? You definitely
there are compatibility issues with software and things like that, which is the bane of our existence in modern medicine.
Nowadays, not. There were some issues when you had different machines, because the vendors out there, the major vendors, GE is one of them, Hologic, those are probably the two biggest vendors. You have Siemens, you have other ones. At the place that I'm at, we have both GE and Hologic. Okay, and they're very similar. And there was a time when you couldn't upload the software, right, from one mammogram to another. But that pretty much is non-existent nowadays. Nowadays, and most places are digital. I mean, film screen is not really something you see nowadays so much. Pretty much every place is digital nowadays. So you go to a place, you can get your mammogram put onto a CD, and there are actually laws that protect women, because the facility has to give them their images. And there's a law out there that says you have to give it to them within like 15 days. Like, there are actually laws that exist to protect women. So, and at our place, we have relationships with some other institutions where we can get electronic transfer of images as well. So I would say absolutely. I think that what's important is to know you need to compare to priors. That's the one important message that we have to give. At our facility, we actually do get the patient to sign a release, and then we will contact the other office and get them to mail it to us. So some places will do that for you.
That's terrific. So moving on, you find something of concern on a mammogram, and then you have to go to another form of imaging. So kind of walk us through what you do next, typically. CAT scan, ultrasound, why you would pick the next modality based on what you're seeing.
Okay, good question also. So you start off with a screening mammogram. So at our place and most places, they are doing a digital mammography, and they're doing what's called tomosynthesis, or it's also called 3D mammography. And that is a mammogram where the woman will experience that the machine moves as they're having their mammogram. That's because the machine is obtaining images, right, at different sections of the breast. It's kind of like a CAT scan. So it slices through the breast. It's like taking a loaf of bread and slicing that loaf of bread. And imagine, like the bread that has raisins, right? So you would be able to cut through and you'll find a raisin on the inside. So it's the same thing with a mammogram. We get those slices. So if I'm reading a screening mammogram, and a screening mammogram is someone that does not have any symptoms whatsoever. If you have a lump, if you have any symptoms whatsoever, then you are not a screening anymore. Then you are what we call a diagnostic mammogram. A diagnostic mammogram means there's an issue, there's a problem, and you will come in, and then your exam will be supervised, usually by a radiologist. Okay, so let's stick to screening. So if I'm sitting and I look at a screening mammogram and I see something abnormal, I'm going to call that patient back for additional imaging. So that's called a callback for additional imaging on another day. When they come back on another day, generally women will have additional mammography images, and sometimes, and oftentimes I should say, they will also have an ultrasound. An ultrasound is a different modality. It doesn't use radiation. It's ultrasound waves. But an ultrasound is very good at being able to detect a mass, a cyst. Sometimes we need to differentiate. Sometimes I look at a mammogram and I see a mass and I can't tell by the mammography because it just looks white. I can't tell if it's a solid mass or if it's a cyst, which is just a round collection of fluid, basically, which is completely benign and nothing to worry about. Once I get to evaluate the patient to see what they have, and it could be calcifications, it could be a mass, it could be what we call architectural distortion. These are all things that terminology that we use. Once we find that, then we have to decide whether that patient is normal and leaves and comes back in another year, or does that patient maybe need to come back in 6 months, or is this patient ready for a biopsy? Nowadays, for the most part, we do image-guided biopsies. It used to be years ago that women would go to the operating room for the surgeon to remove a piece of tissue, right? The entire tissue. And that would lead to scarring, disfigurement sometimes potentially because you're taking, now most biopsies that we do are benign. They're not cancer. So the fact that that what has been developed is image guided means that you could take a patient and just by placing a small needle into the area of abnormality, you could take a piece of the tissue, right? A core, as we say, rather than taking the whole thing out. Once that is done, and that's usually done on a different day, right? Usually not the same day as the callback. The patient then has this biopsy. We find out what it is. And if it's abnormal, the next step is the surgeon. Right?
So that the step that you described is prior to any surgeon getting involved. Do you have any sort of old school Staten Island surgeons that think that that's not the best way to go, out of curiosity, or is that pretty much accepted that there'll be a radiologist that does the biopsy?
When I went from California back to Staten Island back in 1993, at that time, surgeons still believed that women should be going to the operating room. It was very hard for them to accept that there was this thing called image-guided biopsies. And that was part of what I had to teach them. But nowadays, years later, it has become accepted by everyone, radiologists and surgeons, that the first step in biopsying a patient is image-guided biopsy. So the surgeons are completely on board with this because that is the standard It's the standard for American College of Radiology and is the standard for American College of Surgeons, that image-guided biopsy happens first.
So if a woman was recommended to have surgery first, they should be skeptical, is what you're saying.
Yeah, and I don't know where that would be happening, but image-guided biopsies. And, and I should say, I think it's important to say, even though I'm a radiologist and I do image-guided biopsies, surgeons do image-guided biopsies also. A surgeon may see a patient in the office and they may feel something, right? A mass, and many of them are trained and they are accredited. Okay, they get certified to be able to do this. And they, right there in the office, can put the anesthetic on the skin, go in, take a piece, and send it off to the pathology. So at our place at Summit Health, actually, we have both. We have surgeons and radiologists. We both do the procedures. But I would say probably throughout the country, most places it's radiologists that are doing the biopsies.
Got it. All right. So then next steps. Hopefully it's benign. If it's benign, you go back to the usual routine, or is that somebody at higher risk? Just based on the fact that they needed, quote, a biopsy to determine what their status was.
Right. Let's say, let me just give an example. This is a very common mass that we see out there, a fibroadenoma. Okay. So a fibroadenoma presents as a solid mass. And sometimes you can tell that it's a fibroadenoma just by looking at it, and you may follow it, right? But maybe you can't tell. So you do a biopsy. If I do a biopsy, then I have to do what's called assess the concordance. The pathologist tells me what it is, right? They look under the microscope. They send me the report. And then I look at my images and I look at the pathology and I say, you know what? This matches. We're good. She doesn't come back again until another year. Okay. Let's say I biopsy some calcifications and it comes back that it's normal. However, maybe for whatever reason, I think I want to bring her back in 6 months so that I can do magnification views again, just to make sure that whatever piece I took was representative of the entire sample. Sometimes it comes back and there's something called atypia. Mm. So atypia, there's atypical ductal hyperplasia, ADH. There's atypical lobular hyperplasia, ALH. And there's some other ones like flat epithelial atypia. So different types of pathology. If a woman comes back, the pathology comes back as atypical ductal hyperplasia, that patient does have to go on to the surgeon, and that area then needs to be removed. And the reason why is because there are cases where the atypical ductal hyperplasia is just something that's telling you something's going on, and they want to make sure there's no DCIS, ductal carcinoma in situ. So that atypical ductal hyperplasia pathology does go on for more surgery. The other atypias that I've said, they don't. Now, what if I do a biopsy and I feel that it's what we call discordant? Let's say it's an area that looks kind of suspicious. I do the biopsy and it comes back normal, but I say, yeah, this doesn't seem right. Maybe my needle didn't go through to the right place. Maybe it was a mistargeting of some sort. Maybe the patient moved. Maybe the anesthetic moved things. That patient, I may decide that patient needs to go to the surgeon to have a larger area removed to be absolutely certain that there's nothing there.
Yeah. So again, so now we're getting into something that's more severe in terms of the diagnosis of cancer. And I know that you also use MRI technology and other types of technology. So where do they fit in, and what's your part of sort of staging cancers in terms of spread and those type of concerns?
For a cardiologist, Mike, you know a lot about this. You're asking all the right questions for sure. Well, look, sometimes when a patient comes in for a screening mammogram or when she comes back for additional imaging, sometimes I can look at it and I know that I'm looking at cancer. I mean, sometimes that does happen. When you have a patient that has the possibility of cancer or you diagnose them as having cancer, the next step may be to get a breast MRI. So what is a breast MRI? That's magnetic resonance imaging. So breast MRI doesn't use radiation. It uses magnetic and radio waves. It's a completely different method or technology. But a breast MRI is very, very good at picking up invasive breast cancer. So while with a mammogram, especially when the breasts are dense, it may be difficult to see. So the patient may have cancer, but maybe I can't tell how big is the cancer. Like, how are we going to determine if she needs a lumpectomy or a mastectomy? How do we know? So the radiologist can look at these images and say, you know what? I think this patient would benefit from a breast MRI. Now, if you look at what the American College of Radiology will say, they feel that every woman that is diagnosed with breast cancer should have an MRI. But some of our surgeons, some of our colleagues do not believe in that, because there have been some studies, and there haven't been studies that indicate that an MRI really does affect, mortality. So not all patients that get a biopsy and diagnosed with breast cancer, not all of them go on to breast MRI, right? Again, this is where you talk to your physicians, you talk to your radiologists, and you get to find out what you need. So now this breast MRI comes back to me again, and now I have to read the breast MRI. And the breast MRI, what it does is I get to see the breast that has the cancer, try to figure out how big it is, find out if there's any more disease, right? Because you could have one quadrant that has cancer, but you may have cancer in another quadrant of the same breast. You get to look at the lymph nodes to see if there are any in the axilla or elsewhere. And the great thing is that you look at the other side, because about 4 to 5% of contralateral breast cancers may be there. So it gives you an opportunity. If the woman's going to go for surgery, you need to make sure that everything is okay, right? Not just one side. So that breast MRI is going to help to absolutely determine the extent of disease. Okay. Now, go ahead.
I was going to ask you, PET scanning is another modality that people talk about.
I knew you were going to go there. So if a woman has breast cancer and it went to her lymph nodes, right? At that point, the surgeon or the oncologist may say, you know what? I need to make sure, in order to stage this person, I need to make sure that there isn't breast cancer anywhere else. And that's where the PET CT comes in. So PET CT, that's positron emission tomography, right? And there is something called positron emission mammography as well. That's a little bit different. But the PET CT, which, by the way, I did do a fellowship training in nuclear medicine as well when I was at NYU. And PET CT, for me, is one of my favorite technologies. And that's because you look at the whole body all at once. The patient is injected with some radio tracer, right? It gets attached to glucose, and it goes from your veins, it goes throughout your entire body, and it gets picked up wherever there is a lot of uptake with glucose. So active cells, as you could imagine, the brain, right? Our brain is very active. That brain lights up like you wouldn't believe. The heart lights up like crazy. Certain things, the kidneys will light up, everything. But in the breast, for the most part, things are quiet, right? And things like the liver, the bones. So a PET CT scan is a great way to make sure that there isn't cancer anywhere else for that woman with breast cancer. So that definitely does help to stage her. Yes.
So interesting. So I have a couple other questions. Do you routinely look at genetic markers for breast cancer? Is that part of the history when you're looking at the images? Does that help you? Does that hurt you? Just curious your perspective on how important that is. And if you're working in an integrated health system, you may have that, but sometimes you may not have that. So maybe walk us through that, whether or not you recommend those things for women that may be at high historical risk.
Okay. Well, one of the things that when a woman comes in to get a mammogram, we do obtain a history. We have a history sheet that they fill out. And part of that history sheet is to find out, number one, does she have a complaint? We need to know if she has a lump or if she has what we call focal pain, right? We find out about family history. Who else in your family has breast cancer? At what age did they develop breast cancer? Does anybody else have ovarian cancer? And same thing is, have you ever had a biopsy before? And is there any genetic, right, mutation that we should know about? So all of that is extremely important. And as you bring that up, I should also bring up something that's called risk assessment, because a lot of breast imaging facilities have this. They have programs that assess your risk for the development of breast cancer over your lifetime. So one of the ones that we like is called Tyrer-Cuzick. And I can get into that a little bit more later. But you're absolutely right that when a patient walks in, all of her history is very important so that it helps me figure out what I need to do next. It's not going to change how I read her mammogram because I'm there to read the mammogram and find out, is there something abnormal? But if I find out that the woman has this history, and let's say her breasts are extremely dense, right? And we haven't gotten into density yet, but density is one of the things that affects the ability to see tumors on a mammogram. So if that woman has significant history and she has very dense breasts, I may recommend that she have a breast MRI, right? Or I may recommend that she have an ultrasound. Or I may recommend, you know what? You need to see a breast specialist because you also need to see a geneticist to find out about your markers, right? So that patient is going to get plugged in possibly into a high risk program, for example. So you're right. Knowing genetic mutations, absolutely. Now, remember, most women with breast cancer do not have any genetics or any family history. 85% of all breast cancers have nothing to do with family history or genetics.
Interesting.
To continue watching this podcast episode, head over to medevidence.com.